very happy to hear with Dr. Chico. I may call you Dr. Chico because you are known worldwide with that name. But of course he's very happy. We are very happy to have you here and to share a couple of minutes with all your ideas and experience in the QFR. So what can you tell us about your latest experiences? You just wrote a very nice editorial comment for the journal, but QFR in terms of your experiences, where will it go to?
Yeah, I think QFR is a major tool that is going to change the practice in the cath lab, because the evidence is insisting that angiography alone is not enough, that we must guide our interventions based on physiology, but the physiology based in FFR on invasive assessment with a wire is not always possible, it's not always financially possible, and QFR is the tool which is bringing physiology to the vast majority of cases who made profit from that. And I think now we don't have any excuse anymore not to perform a physiologic assessment. And still, if we are hesitating, if we see some contradiction between the data, we still have the possibility to assess invasively the physiology and just for a selected amount of cases, just to find the best intervention for our patients.
Yeah.
And this is the major contribution of QFR.
Yeah, of course we have with all the studies we have shown where the evidence is. We have done thousands of studies or patients, but of course we still know that there are still limitations, that we need to do more studies, like the osteal lesions is still an issue, but we can certainly, together with Dr. Tu, also work on these further improvements of the algorithms. So is that where you see also a big need, osteal lesion assessment, bifurcations? Where is your greatest need, or simplify the procedure?
I think the main concerns, maybe my personal main concerns about using QFR are, of course, in osteal lesions. In bifurcations, I think probably we need to refine a little bit the algorithm, but it's a matter of time that the QFR is perfectly suitable for bifurcations. And my concern is also in sequential lesions. Maybe we need some more specific data reassuring us that we are doing it correctly. And also in calcification. You know that the angiography itself is limited by calcified vessels. So I still may see a limitation in calcified vessels. I wonder how accurate the QFR can be, because QFR is ultimately based on angiography, and a limitation affecting angiography itself may be something that we have to take into account when we interpret the results of the QFR.
Now, of course, with the CT, calcification is a major issue. That it really hampers the segmentation. But in your experience also with the angio, that the calcification limits also the segmentation quite a bit? I thought it was reasonable, but...
I think, the segmentation is okay, but sometimes you know that the border of the angiography is calculated by mathematical algorithms like the second derivative or so, and sometimes the presence of calcium is interfering with the function, and sometimes you have either a more optimistic impression than it is indeed, or the other way around. Sometimes you have a very pessimistic impression, and then when you go, you find that, it was not so bad as you expected. So I think maybe it would be worth to conduct some study just to reassure us how accurate QFR can be in calcified vessels or so. In my personal practice is maybe the scenario in which maybe I are more hesitating, and sometimes I decide, since I don't feel completely confident, then let's go for the invasive.
No, that's certainly a very important point where we can learn from your experience and maybe collect a certain patient set with all those calcifications, see how it works, and if improvements are needed, then we, based on all the evidence, we can also adapt the segmentation algorithms. So that will be, so that it will be even more robust and that we can also have a solution for those particular patient studies.
Absolutely.
And so far, of course, it's an average patient population, of course, that we have collected so far with some exclusion criteria, but it was not, calcification was not an exclusion criterion so far, I believe. But there will also be subsets of patients where we can learn from those experiences.
Yeah, I think maybe retrospective analysis from all the large data collected in a core lab, which analyzes objectively how calcified the vessel can be, or well, we have available even more objective and accurate tools like the CT. That would be fantastic, absolutely fantastic.
Yeah.
And I think there is room to learn still a lot from this specific subset.
Yeah. So I would like to thank you very much, and also for the continuous collaboration and support, and we look forward to hear more from you and from the QFR.
You're very welcome.
Okay.
Thank you very much.
Thank you so much.